Good evening, and we welcome you to the next episode of webinar series Inspire and Ignite. Today, we have a wonderful, powerful talk and panel discussions on best practices and innovations in IVF lab with esteemed faculty amongst us. We thank and welcome the faculty. A warm and hearty welcome to all the attendees. Now, I hand over the proceedings to Dr. Jyoti Malik, Madam, Chairperson, ISAR Haryana. She is the Director, Roots, IVF and Fertility Center, JJ Institute of Medical Science at Bahadurgarh, Haryana.
Yeah, thank you so much. Thank you, Mr. Ameet. Thank you, Jagsonpal. And at the outset, it is my privilege to welcome you all. And it is with a great pride, I can say that this is our second series, Inspire and Ignite, by Haryana ISAR with the motto of Prayas Evam Vistar. So we are doing our best and we are trying to make this knowledge percolate to the roots, to all the people there in Haryana, whoever can join us. And we are trying to reach to the maximum people out there.
So let's move ahead to our speaker. So I have the privilege to invite Dr. Charulata Chatterjee. She is the consultant embryologist, had experience of 30 years in medical diagnostic and ART lab. She is the member of ISAR, ACE and IFS Joint Secretary. She has a lot of work in this field and participated as a speaker in various conferences and CME. So I'm inviting Dr. Charulata Chatterjee for this important session.
Thank you so much, Dr. Manju. And on the onset, I would like to thank ISAR Haryana chapter for inviting me and giving me the opportunity to speak on the topic, which is really very, close to every embryologist heart. So the goal for IVF is, not only as an embryologist to check the fertilization rate or a cleavage rate or a blastocyst rate. The ultimate goal for any clinician or an embryologist is to have the healthy baby, not even in the pregnancy rate. We want having a common goal like what is the birth rate, what is the live baby rate, and for that what is our contemporary goal will be to how to reduce the number of embryo transfer so that there should not be any multiple pregnancy and the baby will be having the live birth. And for that only, when we are going ahead with all now set, that is a single embryo transfer, the embryo assessment is very needed. So the first is why embryo selection, because we feel that every embryos which is morphologically good looking has some kind of viability. So we can transfer any embryo and we'll wait and see that pregnancy occur or not. But no, this approach may not be right, because here it involves cost, the time, the risk of miscarriage, and then having some kind of not prioritization of the embryo will delay the pregnancy for the couple, and that is again an emotional trauma. So we have to pick among all the good looking embryos that which embryo which has the more suitable and viable for the embryo transfer. So for that, what if we have to have the good quality of embryo, basically the quality of gamete which matters. So oocyte and egg, it is a very integral part of the IVF, and that we should check first the role of oocyte. So when we see the oocyte quality, there are three aspects which has to be considered. The morphology we have to see in the oocyte, which is the cumulus cells, and we all know that it kind of sunburst kind of cumulus, then it is M2, the packed cumulus will be M1, and totally packed will be the GV. Then there is a presence of polar body. So if you see the first polar body, it is a mature sign of mature oocyte. We see the meiotic spindle. Of course, meiotic spindle is not visible with the naked eye or with a microscope. We need a specialized microscope, and for that, and we check the oocyte size. Then we see the intracytoplasmic aspect of the abnormality, where we see the cytoplasm. How the cytoplasm, it is the granular, is it having a vacuole, is it having a smooth endoplasmic reticulum, or any other abnormality in the cytoplasm, which definitely affect the developing embryo. Extracytoplasmic abnormality like oocyte size, color, perivitelin space, the granule in the perivitelin space, the zona pellucida, and all this. So it says that the kind of oocyte what we are having in the ICSI will definitely affect the outcome, the embryo. So that's why we have to see the oocyte quality first. And as a conclusion, the intracytoplasmic abnormality like granularity, vacuoles, SCR will affect the embryo quality, whereas extracytoplasmic will not be greatly influence the embryo quality. But here again, what we are not seeing is a genetic chromosomal makeup of an oocyte, the metabolism rate of the oocyte, and the respiration rate of the oocyte. Same way, we have to see the embryo, sperm. When we all know the spermatogenesis will take 74 days to have the complete the cycle for the sperm production. And in that way, there are different factors which affect the sperm and the DNA in the sperm head. If DNA with intra factor or extra factor is affected, the sperm DNA getting fragmented. And such kind of sperm, if we use either for the conventional IVF or for the ICSI, the embryo will be either fragmented, or even if that embryo is good and we transfer that embryo, the lady might land up into the miscarriage. So the quality of sperm is also very, very important. And to have the sperm which is a intact DNA, if there are various tests like, tunnel and sperm chromatin structure as a hello sperm, and if the DNA fragmentation is high, the patient is treated either with the antioxidant, and if with some advanced sperm selection and sperm preparation method like MAX and microfluidics. Whereas IMSI plays also major role, because when we see the sperm at the higher magnification, which is 6,600 times higher than the normal, we might see some vacuoles in the head. And it is said that if vacuole and multiple vacuoles are there in the head, it might have the DNA fragmented. So in that way, suppose IMSI might help to pick up the good morphological sperm. A Pixie is another commercially available kit where we can pick up the good morphological normal sperm. Nowadays, AI also comes into the picture for the oocyte selection and the sperm selection, when thousands and millions of images are stored into the AI, which is machine learning, and it helps us to guide us to pick up the normal sperm for the IVF or ICSI purpose. So this is about sperm and all that. But lab, what about lab? Now we have seen the quality of the gamete. Now we have to see about the embryo development and what the lab plays the role. And it is stated and it is evidence that more than 200 parameters we have to be controlled in the lab to have the good quality of embryos. Out of that, few are like pH, osmolarity, the gas stage, the light, and the instruments, and all that plays a role, and it needs to be controlled. That is the reason the total quality management system is very, very important in an IVF lab. These are I like this slide and I use in most of my presentation. So few lab factors which is coming into the direct contact with the gamete or an embryo. So I have divided into three parts: direct contact, indirect contact, and equipment what we are using in the lab for the development of an embryo. So in direct contact, culture media, the ICSI needles, and the cryopreservation media. Indirect contact is gas, pipes, tubes, whatever catheters we are using, and equipments, all the equipments what we are using in IVF lab has to be, properly maintained. So now coming to the need for the embryo selection, which is today's main topic. And if you see in a brief about embryo development, once either we use any method, conventional IVF or an ICSI for the fertilization, first is the zygote development. What is zygote? Zygote is when we see the two pronuclear into the egg, so which is one from male and one is from female, and then subsequently 2-cell stage, 4-cell stage, 6-cell, 8-cell, morula, and the blastocyst. So this is the developmental stage of an zygote and the embryo. So currently, when we see, but still we are having a limitation in achieving certain percentage of the pregnancy rate, in spite of having good lab, good embryologist, good equipment. Still we are struggling sometimes with the pregnancy rate. So that depends upon the embryo selection also. So there are two methods which is available these days for the assessment. One is non-invasive and the invasive. So what are that? So these are the non-invasive embryo assessment approach which is available. First is morphology, that every lab, each and every lab these days are using. The another is spindle view, embryoscope, which is a time-lapse microscopy. Then in case of non-invasive embryo assessment, omics comes into the picture, where from the spent media, we check the spiruvate, glucose, oxidate, all that. And then there is secreted factors like HLG and secretum that I will discuss again in the next slide. So coming to the first zygote stage embryo, the first and most important thing is the embryo development time. The time is very crucial. It should not be fast growing. It should not be late growing. And for that, we embryologists follow Istanbul consensus, and it has given a specific chart that what time what has to be developed. If you are checking the fertilization stage, it should be 16 to 18 hours post insemination. When we check the day 3 embryo, it should be 68 hours plus or minus 1 hour post insemination. And for day 5, that is for the blastocyst check, it should be 116 hours plus or minus 2 hours. So that way we have to check the embryo when we are using the morphology of the embryo. So there are a method, Gardner, and there are many established method as per the Istanbul consensus, how we grade the embryo. So if we are checking the embryo on day 3 or day 5, there are specific criteria to be considered that and to grade the embryo, whether this embryo is grade 1, grade 2 or grade 3. Now, first let us start with the zygote. When we check the pronucleus under the microscope, we see the nuclear precursor body in the pronucleus. So the alignment of this nuclear precursor body or NPB, it is vary. So these 6 figures tells us how the nuclear precursor bodies are aligned. But the study reveals that when the nuclear precursor body is equal size and it is in the middle of the cytoplasm, then the developing embryos are very good. So considering these 6 Z1, the picture, it will develop into the good quality of embryo. So that is the day 1 we can check about the PN grading. These are the few images from my own lab, which I have seen that different kind of NPB alignment, it is there into the embryo's zygote picture. So now coming to the cleavage stage assessment. Cleavage stage, either we check on day 2, day 3, but mostly we are not disturbing the embryos. We are checking until day 3 only. So day 3, when we check the embryo, what we check? So we check the degree of fragmentation and the equality of the blastomere. So if it is equal blastomere and there is no fragmented, it will be grading as a grade A embryo, which is there in the picture like 1. And we see the multinucleation also at this stage when it is a day 3 embryo. Coming to the day 5, how do we check the day 5 blastocyst? Everyone follows the Gardner method, and he has done a wonderful work by giving us that kind of grading system. So these are the grading system when we see the compaction, the blastocyst, expanded blastocyst, and ultimately the H blastocyst. So these are the grading system. But how do we grade the inner cell mass and the trophectoderm? So when we see, these are the pictures. When we see the grade A, we have to grade A, the inner cell mass should be tightly packed. Grade B, it should be loosely, and grade C, it is not very, kind of very few cells are observed in the inner cell mass. Whereas the trophectoderm, if it is, complete the periphery, then many cells are there, then that blastocyst as graded as grade 1. So considering that, we have to grade the inner cell mass, we have to grade the trophectoderm. Based on that, we can grade the developing blastocyst. So these are the few pictures of the blastocyst based on the ICM and the trophectoderm. Sometimes the morphology may deceive us because anyone can look beautiful these days with the makeup. So how do we say that? How do we, check the good morphology embryo? And then any field, the advancements keep on occurring, and what is constant is only change. First, we used to check the morphology. Now, when the time lapse has come into the picture, it also has a many advantage as well as little, pros and cons both. And there are three kinds of commercially available time lapse are there in the market. So with that, it will useful to grade the embryos. So the main advantage of time lapse it is a constant monitoring with the camera of the developing embryo. So there is no disturbance. Here we can see the pattern of the cleavage. So whether it is a cleavage is 1 cell to 2 cell, 2 cell to 4 cell, or from 2 cell it is going to 3 cell, or any unequal pattern. So that way it will useful us to deselect the embryo if it is the cleavage pattern is different. So we see the morphological evolution. Then if it is the different 3 cell embryo cleavage, we can delete that embryo, and multinucleation with the constant monitoring will help us to select the embryo. So the advantage is better selection of high quality embryo. And when we are not taking the dish out to check the morphology under the microscope, we are not giving any external stress to the embryo, and embryo is developing into in vivo kind of condition. So there is a less stress for the embryo. So that is, good quality embryos can be developed. So that is the advantage of the time lapse. Now, coming to another non-invasive procedure, which is omics, which has many advantage here. So we can check the DNA by kind of NGS technique, that is a new generation sequencing. We can check the transcriptome by PCR something, where we can check the RNAs. We can check the proteins, and we can check the metabolite like lipid, amino acid, and all that. And that is non-invasive because we are checking that from the spent media. So that can be useful to select the embryo, good quality embryo. And invasive method, we have a PGT. So PGT initially it is named as PGS and PGD, but these days it has again renamed as a PGT. And there are three kind of PGT, which is pre-implantation genetic testing. One is to check the PGTA. A stands for aneuploidy. So who are the candidates for PGTA? As per the amendments of Indian kind of government, the lady who is of advanced maternal age, the lady is having a repeated miscarriage, or the lady having a multiple implantation failure can opt for this PGTA, where when we transfer the euploid embryo, the chances of implantation is more because the embryo is euploid. And if the endometrium is favorable, the chances is little higher. And then there is a PGT-M. When the couple is having any monogenetic genetic disorder, that can be ruled out with technique called PGT-M. And if the chromosome having any structural rearrangement, that is SR, PGT-SR. In the down figure, I have seen that how many types of structural abnormality is observed into the chromosome, like deletion, microdeletion, and translocation, and all that. So that can be, when we are doing a karyotype of the couple, we can see that this couple are having any genetic kind of hereditary or a genetic disorder. And then with this couple can be benefited with PGT-SR. So in case of this biopsy, preferably it should be done at the blastocyst stage, and we take the few cells from the trophectoderm, because when we do biopsy on the day 3 embryo, the chances of mosaicism is more, and this a few cells are sent to the genetic lab, and with the array CGS or NGS, they can check that DNA, and they check the that genetic makeup of an embryo, and they can give the report that this embryo is having any kind of genetic abnormality, or embryo is having a aneuploidy or euploidy, and based on that embryo can be selected for the embryo transfer. When I was preparing this presentation this morning, I can come across a very interesting paper which says that this is also an invasive technique. They take it out the little fluid from the blastocyst fluid, and that they check for the proteins available in that fluids, and based on that they indication that which embryo or which blastocyst is having a favorable for the transfer, and which has little more advantage over the other blastocysts for the implantation. And this paper, if anyone's, I can share, it is a beautiful paper how they check the kind of rule out the abnormality based on the blastocyst fluid. Again, these are all the techniques available, but maybe basically it is not very useful in the clinical purpose, but it is there. So the main thing is, I said that you have to check the quality of the gamete, and from the cumulus gene expression we can say that this oocyte will develop into the good quality of embryo. And what are these genes? There is HAS, hyaluronic acid, and then germline. These are the three genes which, if the value of that is high, then this oocyte will develop into the good quality of embryo. And for that, many evidence says that these genes are a good biomarkers for the embryo and pregnancy outcome. This is one of the paper which support about that gene expression test. This is another paper which also supports about the cumulus gene expression. If it is tested in the lab, then that embryo can be that oocyte can be cultured separately, and we can check that embryo, and we can prefer that embryo for the embryo transfer. Again, the proteomics. So, the name itself indicates that we are checking the proteins. So from the spent media, we check the proteins of that embryos have used, and from that we can select the embryo. There are various proteins which can be tested. Now, metabolic activities, as we all know, that developing embryo has a different kind of energy requirement at different stage of the embryo. As in the zygote stage, it needs more of the pyruvate as a source of carbohydrate, but when the develops at the cleavage stage or blastocyst, it take up the glucose as the energy source. Same way as the amino acid and other kind of means energy substrate which can be used by the embryo. And that is the reason, one of the reason that Gardner has come up with the sequential stage media, where we supply that media to the developing embryo. So it is like a back to nature. So whatever it is needed as per the fallopian tube composition, that zygote or an embryo will take as an energy source. And if we check that substrate into spent media, probably we can check it out that which embryo is fit for the transfer. So we check the glucose and then on basis of that glucose consumption, we can see that which embryo is fit. So this are the papers which can give the support that from the glucose estimation or assay, one can select the embryo. Now, same way as the amino acids. There are many studies done into the animal model and few as well as into human model also. And various amino acids like asparagine or glycine, or leucine has a different kind of consumption rate by the embryo, by the developing embryo. And if we check that, we can definitely improve the blastocyst formation rate and ultimately the pregnancy rate. We know oxygen and what is the importance of oxygen into the developing embryo. Initially in the 1978, when the first embryo was developed in the lab, that time we had a very limited knowledge, and from the another like microbiology lab, everyone has used the big box incubator which has a room temperature oxygen which is 2 to 20. But when we see the fluid in the fallopian tube, it is 2 to 8% of O2 level. So that's why the benchtop incubator has been came into the picture. And when the embryo has developed at the 2 to 2 to 8 percentage of O2, that embryos develop very good, and that is good for the embryo transfer. So that is about the oxygen needed for the developing embryo. So now we have checked the morphology, we have checked the embryo by time lapse, we have checked the embryo by omics. So if we combine two technology, it is a better way for the embryo selection. Like suppose we combine the morphokinetics, which is we observe by time lapse microscope, and the metabolism. Like suppose in the time lapse it says it is a fast growing embryo or it's a reverse cleavage. And that embryo, if we check that metabolism rate or omics by proteomics or by glucose consumption, it is vary. So if you combine two technology, it is also a very useful tool for the embryo selection. These are three molecules which we can check into the spent media. One is HLA-G, leptin, and granulocyte colony stimulating factor, GCSF. But these methods are technically very challenging. It cannot be used into the routine lab. So that's why it is used on the research scale only. And this is because there are so many genes has to be checked. So this is the graph and the references where I used to check that polar body biopsy, trophectoderm biopsy, the omics, and what are the references for this paper. So finally, the best is morphology, then there is a time lapse, and there is omics. Now, the future of this embryo selection is one is microfluidics. So suppose we develop such a stage that it constantly supply the nutrients needed by the developing embryo. That way, we can have the command over the embryo growth, and we can check the spent media's like what are the need of the embryo, and that way we can develop the embryo which is most suitable for the embryo transfer. These are the few papers which supports the microfluidics and omics. So how it is useful for the embryo selection. This is also one of the paper which supports for the omics. Now latest comes is the artificial intelligence, which is gaga everywhere. So not only for the embryo selection, AI is the future for the gamete selection also. Few words I have to spoke about for the sperm selection, and there are a few commercial company, two companies I know, which one is for the oocyte selection and one is there in the IVF field for the embryo selection. But maybe some company might come up with the all together, because we have to check the quality of the gamete and the quality of the embryos too. So when we are doing the machine learning, with the thousands of images stored and the data, definitely it is a click away that which oocyte has developed into the one good embryo when we have a single droplet culture. And AI will generate all this, and we have some time to do some other activity, because it will help us to select the embryo into the lab. And there are many papers so far has been published for the embryo selection by artificial intelligence. So it is there are many salient points for the major benefits AI into the IVF lab, because it will minimize the subjective protocols. It reduces the inter and intra observer variability, because every embryologist, whatever I'll say grade 1, maybe some other embryologists will grade as a grade 2. It will decrease the time to pregnancy, because we are transferring the best embryo in the first attempt only. So chances of pregnancy is more. So that's why AI is the future. This is one of the chapter which I wrote in the book. And coming to the conclusion, what is the take home message? Of course, best embryo selection, better pregnancy rate. But if we only focus on one platform, we might, miss the another obvious signal. So whatever available technology we can combine in our lab, and which is with checking that advantage of and disadvantage of that technique without knowing that. I will not suggest to that, oh, that lab has a time lapse, we'll also use. But no, if we know the every use of the technique what we are including in our lab, that is definitely beneficial in some or other way to select the best embryo. Omics is the future. But to me, any technique which we are using in IVF lab should be fast, it should be easy to use, preferably non-invasive, and in India, of course, it should be cost effective. But beside that, the lab SOP and the KPI, key performance indicator, should every embryologist have to keep it in a mind for the good quality of the embryos in the lab. So these are the method for the assessment of the embryo and the embryo selection. This is available for an IVF lab. Thank you.
We like to invite our next speaker, Dr. Paresh Makhwana. Sir is an IVF lab director at Nova Wings IVF group of hospitals and an executive committee member of ACE India, advisory committee member for IFS Gujarat chapter, and Yuva team leader of IHERA, and also being the editorial board member of Journal of MSD Publications, and served as a freelance embryologist in India and West Africa. So for today's talk for Dr. Paresh is invasive PGT versus a non-invasive PGT. We welcome you here for your talk.
Thank you. Good evening all. And thank you, Charu ma'am, for the advanced technique for the selection of the embryo. Here I am just adding one more selection technique for the embryo selection, that is the genetically normal embryos. So we will discuss about the invasive and non-invasive pre-implantation genetic testing. First, I would like to know what is the pre-implantation genetic testing. As we know, this is a technology, it is a multidisciplinary clinical application where genetic technologies and ART are aimed at examining the cells from an embryo in its in vitro development phase. We do PGTA for to know about the aneuploidy, for the monogenic defect, for the structural chromosome rearrangement. And today we discuss about the invasive PGT and non-invasive PGT. So if we discuss about the history of the PGT, how the PGT was started, it is not a new thing. Actually, it's going on since last 30 years. And PGT, the main aim of the PGT is to have a healthy, genetically healthy take-home baby. So it was started before 30 years till 2000. There is a PGT 1.0 era when they were using the fish technique, and fish technique they were just evaluating less than 12 chromosome, mostly focusing on 13, 18, 21 X and Y chromosome. After that, there was PGT 2.0 era started, where there is an introduction of the CGH array, SNP, and qPCR, and blastocyst biopsy was started. But what happened in during that time, two report where they have transferred two aneuploid embryos into a report, and they got a healthy euploid baby. Now there is a question about the PGT was started during this basic era. After that, PGT 3.0 started post 2013. In July 2016, there is a PGDIA society. It was established, and they have given some guidelines for the PGT, and they have given some new name like a mosaicism. We know about the euploid, aneuploid, and the new word come up with the mosaicism, where there is a mixture of the euploid and aneuploid cells were there. And PGDIA society, they have also renamed the PGS and PGD as the PGT, where there is introduction of the NGS chem with a validated algorithm, day 5 biopsy started, and the evaluation of the 24 chromosomes started. So why we are doing the PGT? We are doing some of the indications like advanced maternal age, recurrent implantation failure, severe male factor, and some of the couple with the normal karyotype but having experienced a recurrent miscarriage. We also use for the increasing the pregnancy rate per embryo transfer and decreasing miscarriage rate. And elective single embryo transfer, we know that PGT, it will help to reduce the time to get pregnant. Now there is a one again question is we can use it for the this PGT for all or for the some of the patient, but this is the ongoing discussion. So we will not focus on that PGT for all or not. What is the PGT process? As an embryologist, we will do the biopsy of the polar body, maybe blastomere or prophydoderm. We'll, after doing the biopsy, we collect, we vitrify the embryo, collect that biopsy cells in the PCR tube, sending to the genetic lab, and genetic lab, they will give us the report. There are euploid or aneuploid embryos. After getting a report from the genetic lab, we will thaw the euploid embryos and transfer to the patient. Here you can find these all are the euploid embryos, these are the aneuploid embryos, and this is the mixture of the euploid and aneuploid embryo. This is called mosaic. First, we'll discuss about the invasive PGT. So what is invasive? Invasive, it means that there is involvement of the cutting, infiltrating, puncturing, or incising the skin or other tissue or cells. Likewise, in embryo biopsy, what we do? We will just give a laser shot, or we will, with the help of that biopsy needle, we do the biopsy. It is an invasive procedure. In embryo biopsy involves the removing some cells from the IVF embryo, which can be used for the PGT-A, PGT-M, or PGT-SR. Now, the blastometer biopsy and polar biopsy are outdated, and we are doing the blastocyst biopsy, especially in our country. Most of the people, all the people are doing the blastocyst biopsy, because we know in blastocyst we have more number of the cells, so we can check for the mosaicism, and due to number of the cells are higher, we can have a more DNA available, so we can detect the monogenic disease. There is a natural selection of embryo. That means if we have a 10 M2 on day 0, we know that not all of the embryos are going to be blastocysts on day 5. So only 25 to 50% will convert to the blastocyst, means this is a natural selection. Easier to distinguish cells from the fragments. We will not send the fragmented part, and just will send the trophododon. And nowadays, we are in very advanced era, so we know that vitrification is giving us more than 98% survival rate. When we are talking about the invasive biopsy, invasive PGT, we know we have to have some setting up for a biopsy. It is not like without setting, we can't do it. Like we should have written procedures, set biopsy criteria prior to performing clinical case. This is too much important. If we are not doing biopsy in routine cases at our center, it should be priorly informed before when the patient came, and we should be priorly informed to the lab that we are going to do the biopsy for this patient. So our equipment is installed correctly. We have to check the calibration of the equipment. We have to check the reagent and micro manipulation tools which should be available with us, because it is not like that at the end of the day we are not having the biopsy needle. We cannot do the biopsy. So it will be informed. And so that biopsy, this is a prepared, equilibrated, and clearly labeled. And we have to do all the procedure like ICSI under the oil only to maintain the pH and temperature, because this biopsy will take a longer time than the ICSI. Biopsy procedures is there are 3 points: at opening the zona pellucida, removal of the cellular material, and tubing. So first of all, zona opening. Zona opening, there are 3 techniques: mechanical opening, chemical opening, or photothermolysis. The mechanical opening and chemical opening, they are outdated. Nobody is using this. But nowadays, we all are using the photothermolysis, that is laser. But I will just give you the one video where how they are using that acid thyroid method. You can see here in this video. So you have checked that how the acid thyroid is dissolving the zona pellucida, and we enter inside the embryos. Coming to the laser, right now we all are using the laser. Laser is a device that emits light through a process of optical amplification based on the stimulated emission of the electromagnetic radiation. Simply, the laser means the light film amplification by stimulated emission of radiations. Laser, it is a non-contact laser, reduce time of biopsy, quick, simple and safe. There are lots of literature available that this laser is not going to harm our embryo. They are very simple and safe, because there is a very minimal absorption by the culture dish and the medium. So the characteristic of the laser, wavelength, the wavelength should be remain above 750 nanometer in the infrared region to avoid the mutagenic effect on DNA. power is constant. We cannot change the power. Whatever the manufacturers are there, they are giving the certain amount of power. Like some are giving the 400 megawatts, some are giving the 300 megawatts. We cannot change it, but definitely higher power translating to the larger diameter and increase the heat. Pulse length. Pulse length is vary from 20 microsecond to 1000 microsecond, and that can be controlled by us. We can use the pulse length. If we want a bigger hole, we are having a bigger pulse length. If the smaller hole, we want smaller hole, we are having the smaller pulse length. What is pulse length? Pulse length means when you give a laser shot, the timing for which it is stay at the zona, that timing is called pulse length. Now, when we are going to do biopsy, the points to consider that hatching or non-assisted hatching, timing of zona drilling either on 8 cells or the blastocyst cells, or size of the hatching. So you can do biopsy with the hatching embryo or non-hatching embryo. In hatching embryo, just this is a very simple method. This embryo started to hatch. You have to just catch with the biopsy needle, give the laser shot, and you can do the biopsy. In non-hatching method, this is only the expanded embryo. Here we will give a laser shot. It will start to collapse. Then we will catch this trophoderm and we will do the biopsy. In hatching method, what happened? We have to wait for the embryos till it start to hatch. So it may hatch in the night or maybe in the morning or any time. So we have to again we have to check the embryo, and after the hatching started, we can take the biopsy. Timing of the zona drilling, either you can do on 8 cell or you can do on the blastocyst stage. But the problem with the 8 cell is that we have observed that more than 70% chance that the inner cell mass coming out. So we mostly prefer to do if we are doing the zona drilling, we are doing at the stage of the blastocyst, because at that time inner cell mass is differentiated. We can locate what is the inner cell mass and we can do the zona hatching. Size of the hatching point. Always prefer to do the hatching. The hatching point will be should be very small to do the biopsy. Otherwise, if it is a very big hole, then there is a chance when you do the pulling, the whole embryo will come out. Methods of trophoderm biopsy, either pulling or fluking. So this is the pulling method. In pulling method, hold the embryo with the holding method. This is the biopsy needle. We will catch this trophoderm. We are just targeting 8 to 10 or 6 to 8 cells of the trophoderm. You can see how we are catching the trophoderm, giving laser shot between the two junction of that trophoderm, giving 2-3 laser shot and just pulling with the help of this biopsy needle, and we are doing the biopsy. Coming to the flicking method. Flicking method is, I think, I feel that flicking method is very good, because here we can decrease the amount of the laser shot here. And when the embryo is fully hatched, we must have to do the flicking method only. What flicking method? This is the flicking method where this hatch embryo is catch with the blastocyst or the biopsy needle. This is the holding needle. Just by aligning perfectly, we give the jerk movement. You can see here, yes, and we have cut the trophoderm. Then we will have a beautiful trophoderm cells. This is a non-laser method. Actually, we are not practicing it. I got it from the YouTube only. They are doing the biopsy without using the laser method, and I think it is a very good method. They are not using any laser. They are just catching the trophoderm with the biopsy needle, and you can find they are just coming out of the drop. This is the oil, the border with the media and oil. They are just pulling it, and because of this oil, this trophoderm is separated. So I think this is a very good method where you are not going to use the laser. These are the live cells. These are the intact cells. Target for the intact cells to get a DNA. Rebiopsy of the embryo in case of the failed, incomplete, or inconclusive genetic diagnosis. We have to do the rebiopsy of the embryo. We have we too have an experience for the rebiopsy of the embryo, and there are lots of literature available that rebiopsy are not going to affect the embryo if you are doing the or you are expert in the biopsy. Tubing is very much necessary because whenever we are learning about the blastocyst biopsy, you are focusing on the biopsy only. But at the same time, tubing is too much important, because the cells, the 6 to 8 cells we are getting are very small in a size. So we have to locate those cells. And when we are doing the biopsy, when we are doing the tubing, take care that there should not be any contamination. Witnessing, either we do the non-invasive method or invasive method. Witnessing is too much important because here we have to do a single embryo freezing and a single embryo biopsy, single embryo sampling, then sending the cells from that single embryo to the genetic lab. After genetic lab, we will get a report with the euploid or aneuploid. So there should be some witness. We cannot transfer the aneuploid embryo anyhow by mistake only. So witnessing is too much important here. But what are the major drawbacks of the invasive PGT? So it involves the micromanipulation of the number of embryos of blastocysts. Embryo of blastocysts of only good quality are preferred. We can do biopsy with the poor quality of the embryos. But what happened after doing the biopsy? There are a chance that after thawing that that embryo will not survive if the embryo is not of a good quality. Here you need technologies like laser-assisted hatching, specialized microtools like biopsy needles. The number of biopsy cells may negatively affect the implantation potential. You cannot do the biopsy from the morula or early blastocyst embryos because according to Harton and co-worker, they found that embryoblast cells may be unintentionally aspirated owing to proximity between trophododom and inner cell. Rebiopsy, we have to do rebiopsy in case of the enucleate cell or in case of the failed diagnosis, which again cause harm to the embryos. These challenging techniques require advanced technical skills, constant training in biopsy tubing and fixing. When we are going to do the biopsy, we should be perfect and we should practice it, and we should have we have to do some practice on the left over embryo and become expert. Then and then only we can do the biopsy. Otherwise, there is a chance that you will lose those embryo because what happened here, when you are pulling this prophylaxis, there is a chance you will pull whole embryo and it will be degenerated. You will end up with without embryos. So what is the problem with the invasive PGT? You can see these embryo, these blastocysts are the mosaic. If you are getting your cells from here, you can find there is a 40% mosaic. If you are getting your biopsy from here, that result will be that these are absolutely euploid. If you are getting biopsy from this side, then you will get the result is aneuploid. So in all the cases, these cases only supported this is a mosaic. Otherwise, these both are false negative and false positive case. For all these reasons, alternative PG methods are needed, like they should be safe, reliable, non-invasive with the same efficiency and doesn't damage any part of the developing embryos. So coming to the non-invasive PGT. So what is non-invasive PGT? There is a embryo analysis of the culture environment. We collect the samples, we will collect this media where our embryos are growing. The non-invasive tests that allow us to prioritize for the transfer of the embryos. Recently, the study have discovered that embryo obtained from the IVF treatment naturally release DNA during the development, and that DNA can be helpful to detect there are the euploid or the aneuploid. And the culture medium containing the embryo cell-free DNA can be analyzed by the NGS platform. So when we are going to do the non-invasive PGT, we cannot culture in a group. We have to culture the embryo in a droplet. In droplet, we are culturing. Likewise, your whatever the genetic lab you are supplying, they are giving you their protocol. They want they say that media on day 5 or day 6. According to them, you have to do the culture of the embryos. After a day 5 or day 6, you have to collect your embryo and vitrify it, and remaining the span culture media you have to collect in the PCR tube, sending to the genetic lab, and we'll wait for the result. Here you have to collect all the media because the small amount of DNA should be there in your tubes. What about the media collection? When media collection, you can use either sequencer media, one-step media. There is no matter whichever media you are using, there your protocol is not going to change for the non-invasive PGT. So culture time should be day 5, day 6, or day 7 with any media. Or if we are doing the non-invasive PGT from the embryo, then it should be 24 hours after thawing or 6 to 8 hours with laser-assisted hatching. Media, any media you can use. Media change and washing removal depth. This is too much important because here the main culprit is the maternal DNA. So when we do ICSI, before doing ICSI, we definitely have a habit of doing the denudation of the oocyte. But in this case, we have to clearly wash the oocyte on day 0 to remove as much as possible all the cumulus. After that, when we are transferring the single droplet on day 3 or day 4, again we have to wash all the embryos to remove all the debris or all the cumulus. A day of media collection depend on your genetic lab. The culture media, how much media you need. So if some of the lab they want 10 microliter media, some of the lab they need 30 microliter media for the control droplet. For the sample collection, 10 microliter or 20 microliter protocol given by your genetic lab. So what is the efficacy actually? So Kamen, Rubio and coworker, they were having a very good paper and they have examined over 1,000 of the human blastocysts. And then what they concluded that span blastocyst culture media demonstrate high concordance rate with the trophoderm biopsy, and it can be useful for the prioritizing the embryo euploidy. So they did this research with the all over the world. They collected the blastocysts, and then their main goal was to check for the concordance rate with the trophoderm DNA with the span culture media, inner cell mass DNA with the span culture media. And what they observed that concordance rate between span blastocyst media with the trophoderm 87.5%, span culture media with the ICM 84.4%, and trophoderm and ICM it is 87.5%. They will also check for the different media supplied by the different company like Irvine, Live Global, Sage Media, and also check with the different incubator like Aztec, Miri, Ming, and what they observe, there is no difference between any media you use or any incubator you use. The concordance rate remain the same. Now, what is the detection and quantification in span culture media? So, DNA detection rate, the problem is that the DNA detection rate vary from 46.7% to 100%. According, there are lots of literature there. You can find many authors are there, and they observe 46.7% to 100%. Lowest DNA detection rate was 46.7% because they collected the sample on embryo on day 3. And the highest collection was the 100% DNA detection rate was the 100%. A significant increase in DNA detection amplification rate if they observe the span culture media from blastocyst compared with the cleavage stage embryo. That's why our protocol is for the non-invasive PGT is to culture either day 5 or day 6. Because one of the author has examined this, if you do short incubation, less than 24 hours, then there will be a lower amount of the DNA. So you should have at least more than 40 to 72% of the culture to increase the cell-free DNA quantity. Now, reliability in span culture media and concordance rate. So many authors have examined the concordance rate, which polar body they have observed with the blastomy or trophoderm biopsy, again observed with the whole embryos and the pregnancy. Because the general concordance rate vary from 15.4 to 100%. So why 15.4%? Because it was observed from the arrested embryos. There were 7 studies who reported the general concordance rate between span culture media and embryo trophoderm biopsy was ranged from 50% to 100%. And one of the authors, they observed the range from 65% to the 100% concordance rate. The span culture media PGT also allowed the detection of unbalanced translocation and mosaicism with the help of the NGS. There was one paper, they have recorded 5 healthy pregnancy and 6 live births with a general concordance rate of 100% between span culture media and pregnancies or live births. What is the test sensitivity and precaution? Here we are going to collect the media only. So we are designed to detect the DNA. It is highly prone to contamination because we are dealing with the media. So which are the source of contamination? Cumulus cells or other maternal cells. These are the biggest contamination, biggest culprit for the non-invasive PGT. IVF center personnel and lab personnel, it is same as invasive or non-invasive. Both are same, both are equally important to control this IVF center personnel, lab personnel. What are the precautions you can take? Removal of the cumulus cells and other cellular debris prior to culture on the day 0 as well as on day 3 or day 4. 1 embryo per culture droplet, no need to explain. And change of filter pipette. When you are collecting the samples, your filter pipette should be changed every time. So it cannot be mixed the DNA with each other. And when you are handling the blastocysts or embryos, you have to change your stripper. You cannot use the same stripper for the 2 embryos. What are the technical comparison between non-invasive and invasive? In non-invasive, you don't need a laser. and you don't need to do the biopsy of the embryos. You can do the simply either day 5, 6, or 7. In invasive, day 5 or 6. Here the cell contributing both ICM and prophylaxis, but in case of the invasive, only prophylaxis is contributed. Types of DNA analyzed, cell-free DNA here, here is genomic DNA, and in both cases you can detect the aneuploidy. So there was a literature said the possibility of the harming the embryo is constant concern for doctors and patients, despite the fact that the risk is minimal in the hands of experienced biopsy operator. Though there are experienced biopsy operator, but there is a chance that you will end up with the damaging the embryo, because we don't know what happened. Because what we experience it when we do the ICSI, we can do ICSI by just closing also eye also. Okay, nowadays, but when we are doing the biopsy for each and every embryo, the biopsy technique is different, the control is different, so we have to take care during the biopsy. Now, common comparison between the invasive PGT and non-invasive PGT. What are the benefits of the invasive PGT? They reduce the chance of time to pregnancy. The technology is validated. In terms of protocols, techniques with higher concordance rate and amplification rate, we already know about it. In non-invasive, it is anticipated that less invasive means of acquiring DNA for PGT should be associated with minimal risk to embryos, because we are not going to do any harm to the embryos. And such method could potentially permit the analysis of the embryo pore morphology. This is very much important. In case of non-invasive PGT, we can check from the poor quality embryo also, because it is not going to damage the embryo. The cost of PGT is very low in case of the non-invasive PGT. Why? In invasive, it is higher. What are the disadvantages of the invasive PGT? The embryo biopsy techniques have never been standardized. That means if you follow that between two embryologists, between two centers, the biopsy technique is different, the biopsy, their efficiency is different. It is not standardized yet. And in non-invasive PGT, the more efficiency required non-invasive PGT is to be used, clinically involved to optimization and standardization of the culture condition and medium retrieval protocol. Because some of the the collection of the media, the protocol is still not standardized. Conclusion: I'm talking about the PGT, not non-invasive invasive. It is a single center cohort retrospective study, mostly for the higher implantation rate. If you do the PGT, definitely there is a higher pregnant implantation rate, ongoing pregnancy rate, and lower birth rate, and live birth rate. Sorry. Especially in the advanced maternal age, PGT is very much useful. And according to ASRM guidelines for the single embryo transfer, if you do the single embryo or transfer of the euploid embryo, there is a chance of having a 50% chance of having a pregnancy. Patients should be informed clearly and concisely that the clinical pregnancy rate should not be improved until the further evidence is presented. Now, between invasive and PGT, and invasive PGT and non-invasive PGT. So with non-invasive PGT, current data demonstrate that the span culture media is an alternative approach to obtain embryo DNA. What I feel is that it is the future of the that span culture media is a future for the PGT, because right now what happened that, and some of the centers who doesn't have their own biopsy practitioner, or they don't have their laser machines, or they cannot they are not, because it's costing high, they are not doing the PGT at this moment, because we know in some of the cases, particular cases, the PGT is must needed, but they are not able to do because of this limitation. So they can do the PGT with the help of the non-invasive PGT. But the problem is the huge heterogeneity in literature. Because, however, and the frequent presence of the extra embryonic DNA in span culture media weakens any conclusion on the span culture media PGT diagnosis efficiency and clinical efficacy. Besides, before considering clinical use, to optimize procedures and larger sample size in different IVF centers should thoroughly investigated span culture media PGT reliability. So whenever the counselor are there, and they are counseling the patient, they should inform the patient that when we are doing the embryo biopsy, we are not considering the whole embryo. We are taking few cells. So it may represent the embryo or it may not represent the embryo. So it should be very well known to the patient. Thank you.
Yeah, thank you so much. So yeah, we have Hemant with us, Ajay, Shivani, Tarika, and Dr. Manju, and Dr. Minu, and Vedsa. So just a small introduction with the add-ons and IVF. So IVF is a modern scientific art, I can say. And also, despite robust SOPs and the results tend to be modest and also variable at the least. And to maximize this, the success, which we can say the holy grail of IVF, so there has been a constant struggle for improvement. This is where insidiously this add-ons will creep in. And to start with, I want all the panelists to share their opinion about or the definition about the add-ons. Like, what according to you is the meaning of or definition of an add-on in IVF?
Sanket, I will take this.
Yeah, please go ahead.
Yeah. So earlier we know, as embryologist, as a clinician in the well before, we all worried about only the clinical pregnancy, whether this pregnancy is achieved or not. Now the time has changed. Now we are moving on to the what is the take-home baby, what is the live birth rate, how pregnancy rate, what is the clinical pregnancy, whether it's pregnant or not. Now the time has changed. Now everyone is talking about live birth rate, how we can produce a healthy baby, not only in the pregnancy. In that context, add-ons is going to be, enlighten how we can give the justice to the patient. If you look at what is the add-on in the sense, it is something which is not included in the routine IVF. Like, that is how we can define. No, not as the normal technique we used, ICSI, not only the ICSI, not only the IVF. If it is not good, the gamete is not good, then we can choose for the third party, like the donor, the gamete. It is not like that. In the add-on, in the sense, something we can usually we can go with the diagnosis techniques as well, clinically as well as the embryology. It may the beneficiary, we have to think about it now. Later, how efficacy and outcome of the add-ons, but still, it is add-ons is not regular procedure. It is something it is going to be advanced, which is going to be beneficial to the patient in concern.
So, just to add in this Hemant's description, that add-on just like to improvise the pregnancy rate, you can say, like to improvise just things we can improve the pregnancy rate or live birth rate.
Yes, sir.
We are not using routinely.
I would also like to
extra
add
than the
that
traditional
as a clinician, I think add-on would be something which also decreases our time to pregnancy, which
Yes.
that is equally very, very important. Yeah.
Yes, right.
Right.
Only
Shivani,
for basically indicated patients, we can add the extra services, like the patients who are having the severe, having the high DNA of fragmentations. So what we can do that, where to move ahead, like for the fertilization. So we have to do the DFI. Then after that, patient will went to the antioxidant and just choose the sperm selections method, either max or pixies, whatever. So
basically, add-on is anything extra to the traditional procedure of the IVF and ICSI and whatever we are doing traditionally. Anything to add on to improvise the success rate and to minimize the time of to reach the pregnancy.
yeah,
Yes,
perfect.
sir. Add-on for me is something like beyond traditional techniques which we have been using in the history. But if we add any technique to improvise our result, improvise to giving the clinical pregnancy or take-home baby rate, to increase the take-home baby rate. So that is something add-on for me.
Yeah. So in a nutshell, it is like something like this. It is not a standard of care, but it does have a role to play in order to improve the outcomes. Well, having said that, I think we'll go on to the next question. Charu sir, are you there? I would like to.
Yes, I'm very well here.
Yes, sir.
So just about this first question, I would like to comment here. If you ask me or in a plain person, like what is add-on, my say will be double the pregnancy. Whatever pregnancy rates you are having, whatever is you have to do it and get it increase. That is only the add-ons. Then only add-on will play an important role in the setup. Okay, so we'll move ahead to the second question. Enumerate the add-ons in the embryology lab. What kind of add-ons we can expect in an embryology setup? I think Dr. Ved, you are running an advanced embryology lab, so you can start up with.
So add-on in andrology lab, starting from diagnostic to treatment, we can add like DNA fragmentation. We can test the DNA fragmentation is there in sperm or not, and add on in lab to diagnose other sperm function test to check whether the acrosome is normal or not. And so if you ask me for that, to how to use these techniques in your clinical setup or in your lab. So more for morphology is bad, then you can use IMSI. If DNA fragmentation is high, you can use microfluidic and some other techniques. It is like that.
I'll just add 2 points in that. Artificial activation of sperm by using where we are getting the immortalized sperms.
Right.
Using the pentaxyphilin or theophylline, especially, and DFI definitely will go into the option. Definitely is the option. And even though DFI with varicocele grading, although DFI alone it is not going to fix the problem. If it is varicocele grading is there, then we need to treat the varicocele. Then we have a better outcome comparatively. And apart from automated semen analysis could be the option now. Earlier, no, we don't know the TZI. Now, where the automated semen analysis can tell the morphokinetics of velocities of motility and what is the morphological index of the some semen parameter. In that way, we can definitely choose the advanced sperm selection technique. What we have the microfluidics, where we can reduce the ROS level as well as the less DNA fragmentations by choosing the advanced sperm selection techniques.
Even PIXI we can use in that DNA fragmentation or
yes,
that patient.
Sir, actually, automatic semen analyzers, actually, they are very much available in the market. So we can lower the cost and test reports result is we can get in very less in the time. And there are many parameters we can get in a 40 or 45 minutes. There are many benefits also. There are barcode scanning and one, as I have mentioned, the lower the cost, simple to use, and we can get the good morphology for the ICSI or for IUI, and it gives a good result or any analysis we can provide to the patient. So it is very cost effective and but obvious it is less time it is taking. So I can prefer the automatic semen analyzer is a very friendly to use in the andrology lab, which we can add on in our andrology lab. So
So basically, it's very, very useful tool for the ERT level of one clinic as well, because there's no embryologist or part-time embryologists are available. And sometimes doctors are trying to go to the camps. So
yes, it is very useful for the individual units which we are running. And if they have no andrologist, so they can get it done.
And even there will be no interpersonal variation in this CASA system, automated system.
Okay, so just to summarize this, I would like to make a comment here. All said and done about automatic semen analysis, there is not a single automatic semen analyzer machine available which says that you should not use and wait slide to observe sperm under microscope normally. So yes, CASA has a role, but it is limited.
Yes.
So as far as my take home on this is that you need to still believe on your eyes and what you see under microscope. Second thing is, as an add-on, if we do it in andrology lab, my basic question still remains same, that are we in a position now or are we in an era where we can say that this particular semen sample which comes to me for an examination is proven fertility or is a potential having fertilization? Can we say that?
No.
Dr. Ved, can you say that this sample is having a fertilization potential?
We can just say that after seeing the sperm function test, we can say just it can be But
we can say
but 100% is not possible.
That is where I wanted to have your comment. See, we can increase the probability. We can say that yes, there is a probability, but still it is under observation and under development. Anyway, so our next question was related with this automated semen analysis. So we consider it as an add-on. Definitely, it is going to help us. But still, the most important question which I want to bring in notice here to the panelists, how you can interpret, like suppose you have a semen analysis CASA report where they have written this linear forward progression, this percent, this much, this percent, this much, that percent. What importance does it gives to you, or what understanding it gives to you, or as a clinician, if you give this report to a clinician, what interpretation is there? So I really don't know about this, that 4-page semen analysis report, how it's going to help you. And the most important part is it is an fact that interpreting that report in itself is a big challenge, and many of us doesn't know. At least I don't know what is the significance of all those parameters.
You know,
so Charu sir basically wants to say that based on this report, can you take the decision for the treatment?
That doctors have already said that it is not 100%.
No, sir. This, from my side, I don't take the decision on this report.
Sir, if I consider, so if we go for different tests like ROS, DFI, or vitality test, and then for ROS, considering the ROS, so if we get all the parameters done in one report, and before we get the FERT failure or any abnormalities in embryos, we can get the idea before we go for the procedure. So I think it will helpful for the embryologist and also for the clinician to take the decision before we go for the procedures. I think it is somehow it is useful for us.
Okay, can you tell me how many ICSI cycles you are performing?
Sir, in a month or like in a
No. In routine cases, suppose there are 2 pickups today. Are you going to perform ICSI or not?
Yes, sir.
Okay, then I think Sanket will go to next question.
Yes, sir. But the next question is again about add-ons in Andrology lab. So actually, I just want to conclude what Shivani might be confused why Charu sir shifted to next question. See, Shivani, Charu sir basically wants to say that no matter what report is saying, ultimately you're going to do ICSI. So that is what Charu sir, that is what Charu sir wanted to say.
Right, sir. Got it.
And having said that, what are your opinions about Max as an add-on? Like, is it really useful, or like, is it just an add-on as the name suggests? Like, how do you find, like, because the Max is very kind of expensive technique which you're going to apply, because it's going to cost like 15K per sample. So plus whatever the hospital overheads, and it goes very high, right? So when compared to our conventional sperm preparation techniques like DGC and wash plus swim up. So what is your experience, and does it really any difference in your practice?
I think I am not using that, and I have no experience this product, but maybe some other people, or Sanket, you are using in your center. I know.
Sorry, sir, we are not using that.
We are not using.
Most probably we going for Max better than we going for microfluidics.
Okay.
Maybe I have no.
What about Hemant and Ajay?
Well, in
using the masks.
When Max,
They are not. I don't think so. The Max are using many people.
So Max, when it came, no, then that time it was in hype. Okay, then it is a add-on tool and it's going to be a game changer in andrology and all. Now in the recent era, and the most of Cochrane studies as well as many scientists has told that Max is not recommended to perform, and it's not going to changes in the pregnancy rate as well as increasing the appropriate spermatozoa. That is the concept actually. And in the market now, the lower devices is also there where we can get it for 5,000, 6,000 and all. Definitely, it is not going to help in embryology where we have to process the sample, then later we have to run this through the channel, and which is expressing the caspase protein in the surface of the spermatozoa, which is the magnetic beads which is using in the max. That is sometimes it is not separated as well. Then that is the one main disadvantage as this thing. And definitely it is max is no one using now as of I know. And if it is look at the evidences, it's not showing much differences compared to the traditional or other micropredict. Compared to the micropredict, max is definitely is not an option now.
And even recovery is very less in that sample.
Sir. Yes, sir.
And for poor, the motility is there, and poor morphology is there, then I don't think it will be so much useful, because
it is time taking. Yes,
very less.
Time taking as well.
Yeah, time taking. I don't know, but Sanket is using this. I think.
Yes,
since,
actually, we wanted to conduct a study and we started using this. Of course, it is like not affordable for all. And unfortunately, the product is out of the market now. There is no stock. It is not available in India as such. No? And we are started using second set of Max, which is produced in India itself. So we started a couple of days ago. Yes, sir. So we just started a couple of days ago, and what we found out from past 6 months is yes, Max is not for all the patients, I would say, and it is basically for say high D5 patients where there is slight correlation. What I feel, which again I'm not put in paper to fight for it, but still data is inconclusive as of now, because it is we have not validated it as such, or not published in a paper based on the data which we got. So this is still very too early for me to comment on that, sir. But we're conducting the study. Maybe probably another 6 months we're gonna come out of paper. We'll be producing a paper out of it.
Shall I come in here?
Yes, Dr. Charu.
Yeah, when Max was there, the company who was manufacturing it was on the research scale. That time it was very cheap, say about 6,000 rupees was the cost. And I have done at least 100 to 200 patients, and done the DFI before on the raw semen and after processing of the Max also. One company has agreed to do the DFI for that, and to my surprise that DFI has been reduce in a significant level for that Max. So I find it is beneficial, but after that, when they have seen in the Indian market that everybody is using, and then they take it out the label as only research use, and the cost is more than double, which was not for every couple can affordable. So that's the reason the Max market has gone down, but otherwise the technique is very good, and it definitely reduces DFI.
Just to extend what Charu said, of course, even along with the fragmentation levels, we even got to see that even the embryo formation rate, the blastocyst was quite better in Max.
Yes.
But the numbers are still very too early for us to comment on that, sir. So
sorry, Dr. Charu, just there is one question. Did you able to get good recovery from out of that doing Max? And
the recovery depends again the sample.
Recovery is because it's like a biopsy. A good technician, you cannot leave on the andro technician. You have to yourself do when you are doing the Max. And sometimes the sample is sufficient for conventional IVF, but sometimes it is for the ICSI. But definitely for sample is bad, like OAT or severe OAT, then the recovery is it affects. But otherwise, I have done even conventional IVF with the Max, so it gives good. Because there are two methods when you study there are many literature done by one of Dr. Ashok Agarwal and all that. There is one that some studies suggest that you do sperm preparation and then you do Max. Some studies suggest that you do Max and then do sperm preparation again. So, but I used to do, sperm preparation and then do the Max. So, before we only know that after our good sperm preparation, the yield is very good. Then definitely after that, with Max also, it will be very good.
Thank you.
Sir, I would like to say something what, just to extend what Charu ma'am said. if you ask me personally, out of 300 cases, whatever we have done for max, so in that at least say 15% to 20% was we have done conventional insemination. Most of
Okay,
them are straight
good.
away for ICSI. Yeah, because like high DFI samples, sir. So obviously we will go for ICSI. That was the reason. And where it was at like borderline cases, we even tried IVF, and there is no difference at all. Like even you can try. Again, basically it depends on the samples, so like outcomes, like count and motility. So it is like not all the time you're gonna get a good recovery, as you really correctly said. Yes, we do get a lesser recovery when compared to conventional techniques.
Right, right.
So still a lot of people consider Max as an add-on. So having said that, another player in the market is microfluidics.
So I have used actually.
I have a very
just
bad experience with the microfluidics. Actually, I did one experiment with this device. Actually, I choose the one male patient who are having the more than 50% DFI, right? Then I separate out the sperm through the microfluidics and collect those sperm and perform the DFI test again. And I got like 40-45% DNA fragmentation. So that's why I just avoid these techniques. I basically prefer the big seals or swim slow. Only on this. So that's why I cannot tell the name of the company names. So that's why.
I think, I think I have used this, and we have presented one poster in ACE also, and we found it is very good and useful in high DNA fragmentation patients. And
Exactly,
it is
sir.
very easy to use. And of course, that trial was only for limited patients. It was only for 50 patients we have done. But I think it is useful, and people are using, and it is coming up like that you can decrease the DNA fragmentation after using this technique.
Sir,
And
actually, I have used for the patient for the previous cycle failures and for the male infertility indications if they are having. So we have used the microfluidics and we have got a good blastocyst, and for few patients we have got the pregnancies also. So from my side, good kudos, like use kudos for microfluidics from my side.
So Dr. Ved sir, I had a question as a clinician that whenever we are opting for microfluidics, because at the end of the day we are the face and we need to really talk about, even we need to counsel them on small cost. Patient does come back to us. So one of my question is that you said for increased DFI, this patient, I mean, it could be helpful. So is there a cutoff that that which patients would benefit from microfluidics? Is there some cutoff of a DFI that you take, or what are the other parameters?
So you know that we have used only in patients where DFI was very high, like more than 30. So we have used in those patients only to check that whether that product is from UK, and they sent it for just a trial for me, and we did trial in 5 centers. So 10 patients we have done for each center, and we found very good result out of that DNA fragmentation before and after we checked it. Yes, in few patients it was not like up to the mark, but most of the patients were that DNA fragmentation was less. So that was the result in that. But yes, of course, I haven't used for patients actually. It was just a trial because that product was not FDA approved.
Okay.
And just to extend Dr. Meenu what Ved sir has said, basically you have to look for the technique what they're using, because the cutoff values depends basically on the way you diagnose the DNA fragmentation levels. So for example, you're doing tunnel, the set of cutoff values are different.
Yes.
If you're using SCD, again, that is different. If you're using SCSA, again, it will be different. So basically overall, most of the labs follow, like say 25 to 30%, the higher end. So if it is exceeding more than that, then the decision will be taken to going for microfluidics and max.
Or not for every patient. Actually, you have to decide whether it is implantation failure, that miscarriages are there. Then of course you can use that patients in that, or unexplained fertility. Then definitely you can use this.
So there are times like I don't want to say I found out 0 sperms in the recovery, which have to you go back for the whatever leftover sample and
Yes, yes,
and
you are right. You are right. We have done so many times.
when you
We'll
want to
discuss.
when you want to go have some commitment outside and this happens. Anyways, jokes apart, and Charu sir, next question, please. Charu sir.
Yeah. Yes. Okay, this is something which is very good and lots of people are involved in this. What is opinion and experience of my expert panelists about IMSI and PIXI? Does it really helps?
So I have used that IMSI, not Pixie. In 2-3 patients, I used Pixie, but of course, if IMSI I have used, and I stopped using that IMSI because there was no improvement seen in the patients. Only you can increase the fertilization rate. Yes, you can get better fertilization in these patients, but the outcome is not so good. It was just like same, not improved fertilization rate. So I stopped using that. I have that IMSI and used for so many years, at least 8-9 years, but I stopped after that using it because it's very time consuming. Yeah, very laborious.
Consuming and costly.
Yeah, costly is, of course, it is costly also.
Anyone else want to comment?
Anyone is using Pixie?
I used both IMSI and PIXI. IMSI is long back when we are there in Madam Dr. Kamini ma'am. Universal has installed the IMSI machine. And as Vesar said, that is a very time consuming. And even again, when we look at the evidence-based practice, when the IMSI, there is no significant changes as the same.
Yes.
It increases the fertilization rate, but live birth rate, pregnancy rate, it is as it is same.
Same.
Only that whole thing, it is the vacuoles in the sperm egg that we can identify with the higher
20 or 40.
magnification, where we extended the magnification. That is how when we all know that presence of vacuoles in that can cause the abortion, early trimester abortions in after the implantation. That is one reason. And again, it is the extra add up. Any technique what we are using, it should be helpful to the technicians to know it will to be easy. It should not annoy. In that way,
Yes.
PIXI definitely it is
Yes.
how we are going to do ICSI. Then definitely it is having a good rapport in selecting the sperms which is hyaluron bind the spermatozoa. Then in IDFA cases, just again compared to the whatever technique you use, it should be the technician who is using. You should get it benefit of the patient as well. And at the end of the day, technician also get free hand in choosing the technique. In that way, PIXI definitely is a good option compared. But IMSI, I don't think so. Everyone can afford, and it is as a clinical tool. It is not a clean, effective tool as considering the recent evidences we've seen.
Basically, Hemant wants to say that it's like not an add-on; it is like PR tool more than.
Yes.
Yeah.
So, what are Ajay and Shivani in experiences with IMSI and PXI?
Never done the IMSI before, so no comments on IMSI. But yes, we have done the PIXI out of few patients, and the result was like not much difference between ICSI if we are very good in selection of sperms. So it is good for not for every patient. So we can consider as a add-on PIXI, but not the IMSI.
Okay.
My experience is
there is one Cochrane review, I think 2-3 years back. The PIXI is only where they show that is give better result out of all the add-ons.
So why HFA give the red mark?
Yeah. For HFA, everything is red.
Yeah, it's amber or red basically. That's it.
Yeah.
If Charu ma'am is there, you want to like to comment anything on this?
Yeah. Dr. Charu is there.
Sir.
Yeah, Dr. Charu.
Would you like to comment on this, IMSI or PXI?
Actually, I am not in favor of any of these two. So, like IMSI, it's as everyone has said that it is time consuming. Sometimes, very rarely, it can be useful where there is a multiple vacuoles in the head and very cryptospermic patient or microTISA patient or something very rare, very rare situation. And Pixie, again, it is a choice of, kind of, we all know the principle of behind the Pixie, but that is also, it takes time. So I think if sample is, this is all sperm selection, but if we take care of sperm preparation method by double density or microfluidics or whatever max, then we probably pick up the good, select the good sperm in the normal ICSI dish only.
I agree with the Charu ma'am. That's what I about to say, because if you are good to selecting in sperms, then you don't need to go further. You can go for the ICSI and that's it. You don't need that kind of add-ons in your lab.
So, can I comment here? One important thing I'm noticing, like in this era of Google, so it is not matter of question that whether you would like or dislike it. Suppose some patient comes to your OPD and says that I want to go ahead with Pixie. Are you able to do it? So in that case, what is our option? What we can say to the patient?
So we
So
are offering the Pixie at our center. If the patient is, if after offering the patient, if patient is agree, then definitely we go for the Pixie. But
correct.
if we come for the user-friendly technique, then that's why I mentioned ki if you are good in selecting this pump, so it's okay if you go with the Pixie at itself.
Okay, so we consider we are good in selecting sperms. Sanket sir, we can go ahead with the next question because I
Yes.
think that there will be time constraint also.
Yes, sir. So basically, in the nutshell, all of the panelists will agree it is to come to a very neutral consensus that it is still an add-on, like it is not showing any major benefit in terms of clinical pregnancy rates or live birth
But
rates.
then today's scene, this all facility or this everything should be well aware. People are aware of this and they may ask you. So we should be prepared
sir.
with the answer with that.
True, sir. True.
Very true,
So
sir. Very true.
the next question would be TISA. Again, what is the role of a TISA as an add-on? See, this context is something like different. See, TISA, we do, of course, indicated case, you ignore them. We have to go for TISA or TESA. But for high DFL levels, clinics does TISA, right? So what do you feel about it?
Yes, in few cases, like with high DNA fragmentation index patient and with previous multiple failures, in those cases, yes, there are few studies and RCTs showing that there are with the TISA, results are better than the ejaculated sperm.
Yeah, great sperm. Well,
I think I have used in this TISA in so many patients, and I stop using this TISA unnecessarily, giving torture to the patient, because I found there is no difference in the outcomes. So continuously I used after listening the lecture from Dr. Sandro Esteves. I started after that, and I think if DFI is high, then it is better to go with alternate ejaculation. Ask patient to do that alternate ejaculation and use that sample. It is better to use that sample in spite of this TISA. TISA is unnecessary torture to the patient.
Sir, you mean to say treat a male first, then treat the sperm?
Yeah, either.
Well,
TISA also there is a cutoff. If there is a very high fragmentation index, that will not help. With the TISA also or with the ejaculated sperm also. There is a few cases like cryptospermia and with the moderate kind of sperm DNA fragment index like 20 to 30, that will, in few cases, that will be benefited. But
yeah.
if the DNA fragment index is more than 30 or 40, that will not help.
True, ma'am, agreed. Because see, DNA fragmentation happens at two levels, like internal as well as exogenous. If it is exogenous, fine, it can be controlled. If it is internal, like de novo, then there's no point going for TESA also in case of high DNA fragmentation level, where you cannot control something. So, Hemant and Ajay.
It's only on the isospermic patient, that's it. If there is any high DFI in the sperm, then as I agree with Vaser, I just try to ask the patient to ejaculate. I prefer abstinence basically 0 or 1 day only. This is a study. Many studies have shown that if there's a lesser gaps in the abstinence, then we get the intact DNA sperms.
Sorry, I had got disconnected. I just wanted to add on here.
Please.
Very important thing for when we are doing a counseling for such patients is that if you're just if you're thinking about doing a TISA for somebody who has a high DFI, this is very important that at times, you can also get a dry tap on TISA.
Right.
So it's very important that prior to that, we tell them to give samples every day with lesser abstinence. At least something has to be available for our embryologist.
Right.
And counseling them that we might just get a dry tap. So that's something very, practical point that needs to be noted. Thank you.
So, well, having said that, we got a lot of varied opinions as on TISA as an add-on. And moving on to the next question. I think we already discussed a lot about DFI and ROS. So DFI, initially, if you consider WHO, the very WHO manual in the 5th edition, it was considered as an experimental, but now it has moved to an extended technique when compared to experimental technique. So having said that, we all agree with this. It does help, and it is no more add-on. And for the clinicians here, what are your experiences on the PRP?
Yes, PRP, not for everyone, but yes, in few cases, like where the thin endometrium, refractory cases where are multiple implantation failure, we use PRP for intrauterine insemination. And in these cases, but we didn't find any increase in endometrial thickness. But yes, few and rare cases, we can't say that is because of PRP only. We find some implantation and ongoing pregnancy rate are good. And in some cases of low ovarian reserve cases, we can use intrauterine PRP, intra-ovarian PRP injections. And that leads to better folliculogenesis, and we might get some few eggs for the fertilization. And still it's an experimental technique, and it's invasive also, though intrauterine is not too invasive. So we need to consider all factors, and we counsel the patient accordingly and take proper informed consent, and then only we can go ahead with the PRP.
Right, ma'am. Dr. Meenu?
I totally agree with what Dr. Manju said. And PRP, we are intrauterine because it's less invasive. We can do it per se. But intra-ovarian, we definitely add up with our egg retrievals. And that is the time transvaginally we do add up the PRP. And it's more towards I feel clinically that it improves on, less of cycle cancellations, and the chance of getting an M2 is better. But whether it improves our fertilization or our embryo quality, that is something that we need more studies on. But definitely cycle cancellations and diminished ovarian reserve, it definitely has a good chance.
Well, if you ask us, our own data says that intrauterine, yes, it does have beneficial effects, but intraovarian, I find like very dicey. Like wherever you expect, you won't get result, and sometimes where you don't expect, you will be getting better results. So it is like double-edged sword. Still, I would say.
Yeah, true. But what happens is that as clinicians, before we even take up for a patient for a donor egg cycle, it's very important because psychologically, most of the women are not ready. And here we see that the amount of poor responders that we have is just the number of responders, and diminished egg reserves are increasing day by day. So definitely it adds up to, giving them some hope to do multiple cycles and get their own.
This is only for psychological hope. That is not
No, not for psychological hope.
Result. PRP is only on add-on process for our satisfaction, not in the
I don't agree. As a clinician, I won't agree that this is only for a psychological hope for a patient. We have seen results.
We don't agree for the PRP is the help of the any kind of things.
See, when we are
you're right, sometimes there's PRP, we can't say that this result is because of PRP only, because there is a heterogeneous population also.
The
we
PRP
give a
is not.
different kind of patient.
Yes.
Then in case of the PRP, what happened when patient comes and they read on the Google that PRP is going to increase our ovarian reserve, and we want to try with our own biological egg and we want our own biological child.
Absolutely,
Sometime we after extensive counseling, they want PRP, intra-ovarian PRP, and if they get the result, if it is negative and they accept the donor cycle, the acceptance part is better. Sometimes we find
Absolutely.
that some
And
difficult
yeah.
patient to counsel them is very difficult. It
I
is
agree
not
with
going to improve,
I
and
agree with
they just say, okay, just try it. They are
We
some
just
desperate for
tried.
their
We
own
just say
biological
this.
child.
We just try for this method,
Yeah.
not
You
the
know,
sure that the method is
But
useful for
yes,
us.
we tell them this is a
Yes.
under research and this is a trial
Yes.
technique. Intra-ovarian PRP is a trial technique. This is under research, and we can't say whether we able to get the eggs proper good quality of eggs or not. But
and
still
absolutely, you know,
they
and I
want
I also feel that, you know, as a clinician, you have to help them out. And it definitely, there would be a certain sector of patient, if that improves, we are not able to pinpoint retrospectively that which of the technique or which of the tool really helped us. But yes, that's the reason why add-ons would be given, because there would be some certain 1% of the patient also gets benefited. I, as a clinician, would definitely would
because
like
there are
to.
a lot of, yes, you are right, Meenu, because there are a lot of add-ons. No one is recommended from evidence based. All
Absolutely,
are
yeah.
trial method. So that all depends on your few evidences on the basis of RCT and few of your experience and the patient perspective. We decide whether we take the add-on or not.
Absolutely, absolutely agree. Yeah.
I completely agree with Dr. Manju and Dr. Meenu. Tarika, I slightly disagree with you because see, it is no more placebo effect because see, when you're if you ask me,
No,
I'm
just
cell biologist, I would like to say, see, when you're depositing that protein-rich plasma over there, see, it's like dialogue between the ovary and as well as your endometrial tissues along with this protein, right? So there will be a highly absorbent. I don't know how it works, but it does work in patients. It does wonders, but not like, again. It has not become a standard of care because we need large clinical trials on this and large
lot
consensus.
of research on this.
Yes. And also, yes, as they rightly said, it's all evidence-based medicine, which is we're going to practice and we'll see how this goes in future.
And Dr. Tarika, to come in the evidences, it will take long time. And
Long
there
time. Yes, I
lot of
just defined myself as
research
this.
and lot of, and it will take time
Yeah.
to come in the evidences. But whatever in the clinical setup, whatever we are getting from the add-ons, and all depends on the whole scenario, patient perspectives, doctor perspective, embryologist perspective, and what is the case of that patient. So
See, at
we
All are
times
different.
we do get patients where they undergo this hair transplantation with a lot of follow-up PRPs. They said that it is improving. Why does not it improve the ovary also? Like the patient walk in and they says this to us, and we have to ready to take, at least we have to answer them, right? So
Yeah,
yes.
absolutely. We are talking here for growth factors, and I think all of this, as Dr. Manju rightly pointed out, that it's not that it's going to benefit everybody, but if it benefits few, definitely it would add up to the trials later.
Right. So I think this is extending a lot and going further. Again, there are a lot of add-ons in the embryology lab which we discussed a lot, and we discussed theopneusal also, like based on analogs, like where we don't get to see a motility. How often do you use? Do you really feel this is an add-on, or is it really useful in the lab? Any embryologist can comment on this. So because today we had one micro test in the morning, the harvest was around 35, and my colleague started catching sperms morning around 10:30 in the morning. Pickup was at 2 o'clock in the afternoon. She's still catching the sperms. I don't know. And I had one frozen visa where sperms were horrible. Like I had only 17 oocytes. I injected and came back early. So yes.
Yes, it does help in some
Okay.
patients. We use pentoxifylline for some patient whosoever have done for TISA. But somehow, if we are going for 10 TISA and somehow I got the result in 3 or 4 patients only, and even after adding the pentoxifylline, I didn't get any movement in these sperms. So, as earlier Dr. Ved sir has mentioned that if the DFI is even higher and sperm is very much deteriorated, so there will be no effect, even any add-ons in your techniques. So
I
it
think
depends on patient to patient.
Wait, sir.
Definitely, if motility is issue and it is not moving, then definitely it would help. It will help in those patients. And yes, of course, I am using this and it is very useful in some patients.
It makes
Very
your job easier, sir.
Yeah,
Macro
yeah.
patients,
Yes.
macro
Even-
patients
even-
and or the TISA sample after the
Yes.
thawing, after the warming. This is very
Even
useful.
even I am using collagenase also in TISA sample.
Yeah.
It
Correct.
really helps. It really helps. And
Definitely.
yeah, definitely. It is
Yes.
very
For example, so today I sat for 1 hour for in search of sperms, and for this switching motility, I didn't find any sperm. Then, as in last moment rescue, I added theophylline. Within 10 minutes, I got around 5
Yes. Yes. Yeah, it is very useful actually.
So, again, the spindle view. Who said spindle view? Anybody is using poloscope here?
No, we are not using.
What is
No,
using?
no, we are
But,
not
we are not
advanced
using
enough
this.
to use this side spindle view.
No.
What about Hemant? Hemant, are you there?
I think Hemant has that.
No, not using it, sir. Not using it.
Milan,
You
there
don't
was
have
poloscope,
that.
right?
You don't have that
Yeah,
product.
Milan, I think Milan introduced the first
I
poloscope.
don't have it.
No. Dr. Rishikesh Pai introduced that thing.
Acha, the South India.
The late Sudesh Kamath has lots
Yes,
of
yes.
study on that, and
Yeah.
I have heard him in one
Yeah.
that according to him, he says that in a frozen thawed oocytes, the spindle might some kind of means the placement of the spindle might
Displacement.
vary in the displacement, in the thawed
Agree.
oocytes. So in that case, spindle view help, but that is his study. I have no personal experience.
And you know that Olympus also introduced that one spindle view system, but it was not useful actually.
Yes.
On a lighter
I'm
note,
sure,
sir,
Sanket, you must be using all these advanced techniques in your lab.
No, I'm not using poloscope. Definitely not. On a lighter note, what happened today was, see, I was doing this PPT and my junior saw this and I just said, Tessa is an add-on. She saw that, right? After that, I asked for theophylline after 1 hour. She said, so one more add-on. Add-on or add-on? I was like, add-on plus add-on. Indro to aayega na, de do. So yeah, next is the much discussed the topic time lapse.
So I am not using, but it is definitely
I'm using this, and
who is using?
I'm
Tarika.
Yeah.
Yeah, Tarika.
I have an embryoscope in my lab, and the result is very, very change. For blastocysts, I'm happy with this time lapse. Non-disturb culture system. I like this.
So basically, you're using for deselection of the embryos, right?
Yeah.
Yes.
Okay. Ajay or
Don't never use this. Yeah.
used. Delhi.
Hemant.
Yes, sir. Use this, sir. This thing again, the same again. Add-on cost, and again we do if you. It is good actually. The instrument is good, but we need to spend a lot of time to understand what exactly the time lapse has been made up of. That morphokinetics. And blastocyst conversion, it is we can do it in any way. If the culture system is good and optimum environmental is good, we can culture in blastocyst. Conversion is any in the box of incubator also we can do it. Nothing related with time lapse. But again, the good tool and good marketing tool as well, and we can easy to convince the patient if it is
and
how they have
a good price also.
But again, comparatively, as we look up to the pregnancy rate as well, the live birth rate, definitely there is not much change.
No much change.
But definitely we need to spend a lot of time to understand then what embryo to select, how it develop and all. Not just a blastocyst, the whole event
The
of
whole process of
Embryogenesis, we need to see in the
Yes.
individually all the checkpoints, then we use.
Right,
For
right.
research purpose, definitely is going to be a great tool,
Yes.
not for routine use.
Not for
And see, recently one of the closed meetings I met Ramaraju sir from ISAC. So he was saying, sir was saying like he's using time lapse for all the cases in his lab. And he said he's going to produce paper on also on that. Maybe we have to wait for the paper. We'll see how it is improving the success rates. So
he is using that Genia.
Definitely, it's a marketing tool again as the patient as well. But if you do buying the machine and doing it free for this thing and all, definitely again.
Yes, yes.
Yeah, and centers are doing extremely busy practice. This will become an add-on as a PR tool.
Yes.
Again, yeah, electronic witnessing, anybody's using, what are the experiences? Do you really feel it is an add-on, or does it have any impact on the practice as well as outcome?
I have electronic witnessing system in my lab, and I don't think so that the add-on is okay, because there is no changing in our routine practice. They're just good for juniors, not for us.
Yeah.
I don't think so.
After
It's
using
only
electronic
the-
witnessing, so we have to do the double manual witnessing as well. So what is
Yeah.
the benefit of this?
What is the benefit?
Basically, it's a
Benefit,
trauma, mental trauma. कभी नेट नहीं आ रहा, कभी कुछ
कभी
issues होते
नेटवर्क
हैं,
नहीं आ रहा है,
yeah,
कभी
so-
बारकोड एक्सेस नहीं हो
Horrible.
रहा है, तो सारा सब कुछ मिक्सअप हो जाता है ना.
Even
I don't think so कि that
what-
is the good for लैब की. वो कहते हैं ना कि लैब में कुछ चीजें ऐड करनी हो लैब शो के लिए, तो ओके, it is
Yes.
okay. We have electronic witnessing system.
even
बस
sometime
उतना
what
ही.
happen actually, what happen if in starting when you preparing the barcode, if you mention wrong thing over there, the whole process will go.
Yeah. So
Yeah,
I'll
yes,
come
sir.
there. So I'll come there.
You have to, you have to think about
What
that
happens, sir,
also.
what happens is, I do agree with all of them, but the point here is, see, when you're having a busy center, when you're doing multiple cases in a day,
Yeah.
and multiple operators, see, one person is processing a sperm, one
But
person.
Sanket is tracking only the dishes, RFID.
Right. Let me
गाड़ी
come
में
to that.
RFID को ट्रैक करते हैं, बस मैं ड्राइवर क्रिमिनल बैठा है, कौन बैठा है उसका नहीं पता ना.
Not that way. See, it is like this. It is like this. See, personally, I am not a big fan of this witnessing, but still, how it helps is what I'm going to say now. Because see, this alignment of tags is very important, the initial step.
Yes.
When you align the tags, the number of tags for each process, for example, some labs use 5, some labs use 10 for very important steps they're using, right? This alignment takes time, very time consuming this is. In this also, as you rightly said, we need manual witnessing also. See, one person is saying, so on XYZ patient. So this XYZ patient has to be typed in the system. Then you have to align a tag. Again, once it is done, then next is a cakewalk. But this aligning will take time. And yes, initially little hiccups with this system. But still, when multiple people are handling multiple samples, I think it is worth, because we don't know, as a humans, we tend to make mistakes, like which is like you're putting a checkpoint over there with this electronic witnessing. What I would like to say.
Basically, this checkpoints how basically exposures, how much time the gametes are exposed.
The system,
for the particular steps. Like
the moment other dish comes in the periphery, for items do not touch. Then you have to do admin access. You have to write a reason. It's like I start when this was introduced in our lab. I was like, मैं तो कुछ नहीं करूंगा, सब टैग करके मेरे को बुला, मैं आके केस करके जाऊंगा बस. बाद में, when they tag the XC dish, half of the region is gone. See, I need PVP drop in the corner, one HEPIS drop in the corner for the manipulation, which is gone because the tag is covering that. You can't make out when you keep it on with your inverted microscope. So, anybody else, any experiences with witnessing?
Horrible.
Yeah, so still this is an add-on, and
it is good for patient satisfaction only.
No, madam, patients got confused. If you explain about the we have electronic
patient को जैसे हम लोग को कार्ड देते हैं ना, तो patient अगर मैडम ये कार्ड लगेगा तो मेरा नाम बोलेगा,
if you have an electronic witnessing system, you have to implement it on internal protocols. You do not sell to the individual patients. Like you give the option for the patients. Like we have if you want to opt the electronic witnessing systems, then when you give the offer, the patient get confused. वो बोलेगा कि कहीं ना कहीं यहाँ पर कुछ ना कुछ लोचा होता है, कुछ ना कुछ होता है यहाँ पर मिक्सिंग का, तो दैट्स व्हाई दे ऑफरिंग मी. सो आई डोंट थिंक सो कि अगर इफ यू वांट टू इम्प्लीमेंट इलेक्ट्रॉनिक मेडिसिन सिस्टम, यू हैव टू
पेशेंट खुद
इम्प्लीमेंट
चला के
इंटरनेट प्रोटोकॉल
बोलता है आके.
for the patients.
See, it is like this, as you rightly said, when you're having a 6x2 lab and with two stereosomes, one can be used for witnessing, other can be used for manual. It is up to you. It is like customizable, right?
Yeah.
So,
Yes.
so again, yeah, a lot of other questions. Charu sir, last two questions.
चलने दो. I think QA and QC, this is most important part of the discussion, I suppose. It's a definite add-on.
Sanket, we have a meeting.
Yeah, sir, we have a meeting 8 o'clock. Yeah, yes.
That's why we have to wind up.
All of us have to go, sir. Yeah.
Yeah, that's why.
So just one line statement from panelists. QA, QC, they think it is an add-on needed or not?
Yeah, it is
Yes.
needed.
Add-on,
Yes, definitely add-on, sir.
It's
Must needed.
definitely
Without
add-on.
QA,
Okay.
we not survive our lab.
And the
Okay,
top of the
so
town, AI.
the next is automation
AI.
in IVF, AI, semen analysis, embryo grading, vitrification, ICSI. How many of you feel that if AI is introduced in lab, your job is going to be very easy, or it's going to be more responsible?
Again, it's an add-on, sir.
Yeah,
Again,
add-on.
it's
It
an
is
add-on for
total.
embryology.
It is add-on.
Add-on for embryology. Yes, anyway, physical.
Because I am still finding a question, answer to this question, that if something goes wrong by AI, suppose you have a
What we
robot
now
installed, who is
after
going
that
to be responsible? Who is going to be responsible for that
AI.
mistake? Is it
AI.
AI? No, unfortunately, it is the person who is handling.
No, sir, I don't agree with AI.
Okay. So,
हम
any
सब
more
कुछ खुद
questions,
करना
Sanket?
चाहते हैं.
No, but ultimately, I see the future of AI is there. It will definitely come in labs, and we have to
Yes,
gear
sir.
it up to cope up with this things.
Well, we'll not
PGTA.
discuss about this. Yeah, again, we all have a very clear consensus about this now, where to apply PGTA and PGTM as well as SR. So we'll skip this question and yeah. Sorry, somebody was saying something.
No.
Yeah.
Carry on.
So the take-home message will be, it is imperative as we realize that what constitutes as an add-on, and probably even before thinking of its success rates, and anything when applied without a definite benefit in majority of the patients to be considered as an add-on, especially when the benefits do not result in significant change in the outcomes. Also, numerous add-ons available in the Embryology lab, diagnostic, especially the therapeutic as well, where say even the QA and QC will be considered as an add-on at times. Having said that, yeah, thank you so much for your kind cooperation for this wonderful panel.
Thank you.
Thank you, Charu sir. Thank you, Sanket. Thank you, Ved
Thank
sir.
you.
Thank you, sir.
Thank you,
Thank you,
Charu.
sir.
Thank you, Charulata ma'am.
Thank you.
Thank you.
Thank you.
Thank you,
I
sir.
think
Thank you,
that
sir.
was again an amazing panel. I mean, I've yet to see embryologists of such high world-class quality here that we could see today on the same platform, and amazing work that you have been doing. I mean, it is such high-end on things you have been talking of, and I'm sure we have gained a lot, and I don't know how much add-on we can do in our labs with such high-end things going on. But I think it is actually we have to know each and everything, and I thank Dr. Ved Prakash sir for bringing
Thank
us
you.
all these gem of embryologists here in this platform today.
Thank you.
Dr. Sanket, you have been amazing. Charudutt sir, you are very generous. I mean, you don't want to go so high end on, and thank God you are there.
But whole point here is, madam, that we should be geared up.
Hemant, I think with the addition of an AI, I think Embryology should not become an add-on.
Exactly.
And especially with robotic ICSI coming in now.
Yeah, robotic ICSI, robotic vitrification, will we just switch on the machine?
Robotic ICSI, that validation is still under
Yeah.
validation.
Mm.
Again, it is not completely making ICSI. Then we need embryologists should need for that to align it, to place it, and it is a long way to go.
Yeah.
I think we don't have to worry because see, even this Da Vinci or whatever, the robotic surgeries, what they do, is very expensive. I hope that this robotic XP also will be expensive and people cannot afford it and will like living with own conventional techniques.
Yeah, so thank you so much, our panelists, Dr. Hemant, Dr. Ajay, Dr. Shivani, Dr. Tarika, Dr. Manju Dagar, Dr. Meenu Handa, and our moderators, Dr. Charudutt sir and Dr. Sanket sir, and of all the people, Dr. Ved Prakash sir. So in the end, since we are already half an hour late, I would request Dr. Manju to please thank us, being the vice chairperson. We also have a list of our executive members. If you have that list, Dr. Manju, we can read out the name, or I can read out the name. In our embryology committee, we have, apart from our chairpersons and vice chairperson, Dr. Shilpa, Marwah, Dr. Gurnesh, Dr. Kerina, Dr. Anurag Bishnoi, Dr. Surender Yadav, Dr. Bhavna Agarwal, Dr. Kunika Chechi, Dr. Shweta, Dr. Sarah Preet, and Dr. Praveen Upadhyay, who are our committee members. And I would like to thank them all to be a part of this great team. And I hand over to Dr. Manju to thank all.
Thank you, Dr. Jyoti. So on the behalf of Embryology Committee ISAR Haryana, I would like to extend our heartfelt gratitude to each and every one of you, gracing us with the presence of your today's special thanks to Dr. Nandita, Dr. Charudutt, Dr. Ameet Patki, Dr. Asha Baxi, and Dr. Ved Prakash. It has been an honor to privilege to host such an esteemed gathering dedicated to the exploration and advancement of the embryology. I would like to express our deepest appreciation to our distinguished speaker panelists for sharing their invaluable insight and expertise. Last but not least, we extend our thanks to each and every attendee of your enthusiastic participation and meaningful contribution. Thank you once again, and special thanks to Ved sir.
Thank you. Thank you. Thank you. Thank you so much. Thank you, everyone.
Thank you, Dr.
Thank you, Jagsonpal.